Good morning, everyone. The topic of my presentation is unilateral versus bilateral strabismus surgery in intermittent exotropia with lateral incompetence. Lateral incompetence is defined as difference in amount of deviation in primary gaze and lateral gaze. It is considered to be significant when this difference is more than or equal to 20% but less than or equal to 50%. Lateral incompetence can be treated with bilateral or unilateral strabismus surgery. This study aimed at comparing the post-op alignment, lateral incompetence, ocular motility limitation, and binocularity after the above two approaches. This was a prospective randomized interventional comparative study done in Department of Ophthalmology in Maulana Azad Medical College, including 40 patients who were randomly equally divided into two groups, Group B and U. B included who underwent bilateral asymmetric LR recession, while Group U underwent unilateral RNR surgery. Inclusion criteria: the patients more than 7 years of age with intermittent exotropia with equal vision in both the eyes with amount of deviation between 15 to 35 prism diopters were included in the study. The primary outcome was assessed at 24 weeks, that is at 6 months, in the form of changes in lateral incompetence in each group and comparison of change in lateral incompetence in between the two groups. The mean pre-op deviation for distance was 28.75 prism diopters in a bilateral group, while in 29.25 prism diopters in unilateral group. The mean pre-op lateral incompetence in Group B and U were 8.3 prism diopters and 8.9 prism diopters respectively. The mean post-operative lateral incompetence in Group B was 2.8 prism diopters, while in Group U was 3.7 prism diopters. The clinical relevance of lateral incompetence in intermittent exotropia has been subject of debate since long. Few studies found that the patients operated without taking into consideration the significant pre-op lateral incompetence were likely to be overcorrected with the surgery in the gaze towards the reduced pre-op deviation. Moore and others have recommended to reduce the amount of the recession in patients with lateral incompetence, as large recession decreases the full abduction movement, while the study done by Dade and Kamle showed no such correlation. Yoon and Kim compared the bilateral and unilateral recession but did not include the results of the resection surgery. Graper and Hunter evaluated the effect of asymmetric horizontal surgery on lateral incompetence in the form of change in competence, and they concluded that asymmetric surgery can cause as well as treat lateral incompetence. Ours is a prospective randomized study including 40 patients. There was no statistical significant difference between the post-op lateral incompetence between the two groups, but a significant difference was observed between the pre-op and post-op lateral incompetence in each group. We had a successful outcome in the form 90% in bilateral group, while 85% in unilateral group. And the prevalence of lateral incompetence over a period of 12 months follow-up was 19.4%. And this has been variably reported in the literature between 2.2 to 60.3%. So we conclude that both the procedures are equally efficacious in achieving acceptable ocular alignment and treating the significant lateral incompetence in patients with IDS with deviations between 15 to 35 prism diopters. Bilateral asymmetric LR recession reduces the limitation of ocular movement and lowers the risk of post-op lateral incompetence, while unilateral RNR surgery preserves the muscles of the fellow eye and reduces the surgical time and usually preferred by the patient. This was a pilot study to do a prospective analysis of comparison between the two procedures. With the limitation of our study were the short follow-up of 6 months and the small sample size. A study with larger sample size and longer follow-up would be required to draw the definitive conclusion. Thank you.
Are we allowed to ask questions here?
Yeah, you can ask.
Okay.
Yeah.
I just have a question for you. What measures did you take to ensure that there was no fallacy because of the position of the prisms?
Ma'am, actually the study which was done by Arnoldi et al., they concluded that if you keep the prisms in the adducting eye while measuring the lateral incompetence over the adducting eye, then the fallacy would be reduced. But it has not been reported anywhere how to measure it. Only in his study only is mentioned that if you do in adduction, then only measurement would be accurate.
Okay.
Not over the abducting eye.
Okay. So you made sure that you kept it in the adducting
Over
eye.
the adducting eye.
So do you know why it's in adduction? Why it's in adduction?
Sir, actually I tried to find out in the literature, but in that we could not find the reason why it was placed.
Okay. Anyway, I'll just tell you that most of the time what happens, these intermittent XT, they are long standing, so their lateral rectus is usually on table tight. And that's how usually they do have even the adduction limitation of like minus half or 1 sometime.
Yes, sir.
So in fact, that decision of how much to do, like BLR versus R&R, depends upon on table how the LR is, the tightness, right? So that would also change the dose.
Okay, sir.
Okay, thank you.
Thank you.